Visible. Can you all give me a quick thumbs up if you can hear me and if you can see my video well? Fine, just let me check if everyone can see it. Yes, great. So welcome all of you. Let us begin with the today's session of crash course of dermatology through MCQ. Now let me introduce myself. I'm Dr. Chesta Aggarwal, your NEET PG educator on Unacademy. I have myself scored All India rank 261 in my NEET PG entrance examination. Now we will be doing a lot of MCQs in these series, and I would request all of you to kindly join me every day. We have multiple sessions on them. Before we go ahead, let me introduce about a new feature which was introduced on the app, and that is Compete. Here you can battle and you can know where exactly you stand. So what you have to do, you have to just download the Android app of Unacademy, and there you have to select for Compete. The app will automatically select a competitor for you, and you can battle them and can have a lot of MCQ based discussions. Now on Unacademy, we have currently a very reduced price of the subscriptions of Unacademy. So kindly use my code CHESTA10 CHESTA10 and get your Unacademy subscription with 10% discount. Starting with the questions of this session, just give me a second. Let us start with the questions of this sessions here. Follicular hyperkeratosis is related to the deficiency of. Good evening to all of you. I want everyone to please answer this. Dr. Abhi, Kunal, Rajesh, very nice. Great. So follicular hyperkeratosis, which means if this is the skin and these are the hair follicles which is coming out, you see thickening here only over the hair follicular areas. This is a very characteristic feature of vitamin A deficiency. And can you tell me what is it called as? Anyone? It is known as Pyoderma or toad skin. It is known as Pyoderma or toad skin. The follicular keratosis, which is mainly present on the extensors like elbow, knee, known as Pyoderma or the toad skin. Moving to the next question. Please tell me the correct answer here. Allergen responsible for this condition. Allergen responsible for this condition: paraphenyldiamine, formaldehyde, epoxy resin or ammonia. What is the correct answer? So there is a procedure being done which is shown in the image. You can see that patient is dyeing the hair. Now in the hair dye there is a very special allergen which is known as PPD, paraphenyldiamine. It causes allergic contact dermatitis. Now we all know that the allergic contact dermatitis usually occurs in the area beyond its application. So you can see that there is lesions on the face, on the neck, even though the patient have not applied the dye on these areas, but still he is developing the allergy. So allergen responsible for this condition, that is PPD. Clear? Paraphenyldiamine. What is the answer here? Very nice, great. So identify the test: prick test, patch test, Pathergy test. So one thing is, yes, it's a very clear example of a patch test. Please remember, patch test is a type 4 hypersensitivity reaction. It is considered to be the investigation of choice for allergic contact dermatitis. It is treatment of choice for allergic contact dermatitis. We remove the patch on day 2, that is 48 hours, and we read the patch on 96 hours, that is day 4. Next question is on your computer screen. False about trichorexis invaginata is. What is false about trichorexis invaginata? So, what is trichorexis invaginata? One part of the hair invaginate into the another part, such that the part which is receiving it becomes like a socket, and the part which is entering it becomes like a ball. And that is why this deformity is also known as ball and socket deformity. Now if you have seen, the bamboo tree is something like this, right? And that is why it is known as bamboo hair deformity. It is a very classical feature of Nystatin syndrome. Now this is a defect of hair shaft. It is a defect of hair shaft. It is not a defect of melanin synthesis. So please remember, this is the correct answer. Option number 4. Bamboo hair deformity is the correct answer. Ball and socket deformity is the correct answer. Associated with Nystatin syndrome is correct, but option number 4 is incorrect. Next. Now granuloma annulare, it is because of damage to the collagen. It occurs because of damage to collagen. So what happened? There is collagenolysis. Whenever you have damage to collagen, you develop necrobiotic granulomas. And these granulomas will clinically give rise to raised lesions, which is skin colored. I want all of you to please look at this. Can you see this raised color lesions? Now this is occurring because there is a granuloma formation. It is more common in the conditions like diabetes or those who have excessive exposure to sunlight. It occurs mainly on the exposed areas. You can give steroids to take care of them. There is no ulcerative lesions, or very rarely you see any ulcers which are present in association with them. So the incorrect statement is option number 4. Clear? Next. Anyone? Anybody can tell me the answer here? Great. What is onychomycosis? It is the fungal infection of the nail. Now, in onychomycosis, we give a special formulation of antifungals, and that is known as nail lacquer. Now, they are thick, sticky formulation which remains on the nail plate for a longer duration. There are two formulations which comes under the nail lacquer. One is Amorolfine and another is cyclopyrox. Amorolfine or cyclopyrox. So these individuals should be prescribed either of these two. Amorolfine, it is a cell membrane inhibitor. It prevents the new synthesis. So ergosterol synthesis is prevented. Prevent the new synthesis of the cell membrane. While cyclopyrox, it is inhibitor of enzyme which require metal as the cofactor. Metallic cofactor enzymes. Both of them work very well as a nail lacquer. So the correct answer is option number 4. Next. A patient presents with blue-purple asymptomatic lesions on the face on the sun-exposed area. What is the likely diagnosis? Very classical feature, blue purple asymptomatic lesions on the face on sun exposed areas. Very nice. The answer is lichen planus. Now in DLE, the classical appearance is annular lesion with atrophy in the center. There is atrophy of the center plus there is hyperpigmented margin. Atrophy in the center and there is hyperpigmented margin. That is a very characteristic feature of DLE. In lichen planus, we have a variant which is known as lichen planopigmentosus. Now it is a variety of lichen planus where you will only see pigmentation, and that is also a bluish type of pigmentation. What is the reason why these individuals develop these bluish type of pigmentation? The reason here is because in these individuals there is a very classical damage to the stratum basale layer. So all that melanin, they falls down in the dermis without irritating any of the other tissue, and that is why there is no itching. Even there is no stimulation of the stratum basale to proliferate. So there is no papule formation. It is just a pigmentation which is bluish in color. So the answer to this question is option number 1, that is lichen planus, and its variant lichen planopigmentosus. Next. Anybody can tell me the answer here? What is the correct answer in this? A 55-year-old farmer with black mole on the cheek. It is increasing in size, becoming irregular and invading in the deep tissue. Very important point. Great. Now one thing is clear, that all of these are examples of melanoma, so that we don't have to make a diagnosis. But how to differentiate? So please remember, all my students, in melanoma, whenever there is invasion in the deep tissue, whenever there is vertical spread is seen in a nodular form, while in acral, in superficial variety, and in Lentigo maligna you have horizontal spread. This we are talking with respect to histopathology. So we have classified melanomas into two groups. In one where there is vertical spread, that is nodular, and another where the tumor cells they spread horizontally first, it is acral, lentigo and superficial. Please remember, because of penetration in a vertical direction, nodular melanoma has a very poor prognosis. It has a very poor prognosis because the lesion will transfer in a vertical direction. So it is very early for them to spread. Very early for them to spread. Yeah. Next. What is the correct answer here? A patient with HIV has white plaque on the uvula. Pseudohyphae was seen on microscopy. What can be the likely diagnosis? Aman, I think it's going fine from my end. So I would recommend you to kindly check the internet at your end because it's going smooth. It's fine in my mobile as well. Great. A patient with HIV has a white plaque on the uvula. HIV means they are asking about immunosuppressed status and presence of pseudohyphae. So it means budding yeast. Budding yeast. So we have pseudohyphae and immunocompromised patient. This gives you an idea that this white color plaque is nothing but oral acute pseudomembranous candidiasis, which is known as oral thrush. So the correct answer here becomes option number 1. Next. Which of the following does not causes urethritis in male? Very simple question. We have seen this question has been repeated so many times. Which of the following does not causes urethritis in male? Now please remember, urethritis, there are two main causes. One is gonococcal and non-gonococcal. In gonococcal urethritis, it is Neisseria gonorrhea. But in non-gonococcal, it is chlamydia, ureaplasma, mycoplasma. It is chlamydia, ureaplasma, mycoplasma as well as trichomonias. Now I am sure that a lot of you got confused because of this vaginalis term. Please remember, trichomonas cause vaginal infection in females. But in males, it is not causing vaginitis, but it can cause urethritis. So please remember, which does not cause urethritis in male? The answer is option number 1. Trichomonas vaginalis is a very common cause or very popularly known cause for non-gonococcal type of urethritis. But Haemophilus ducreyi, it is the cause for genital ulcer, not urethritis. Did you understand? So I think nobody have given me the correct answer. Only few, very few students have given me the correct answer. Please remember, it is option number 1, not option number 3. Do not get confused with vaginalis term. It can cause urethritis in male, but it never cause vaginal infection in males because there is no vagina obviously. Haemophilus ducreyi is known to cause the genital ulcer, not urethritis. Next question. A child with scaly dry skin, he has colloidal membrane at birth. What can be the diagnosis? A child with scaly dry skin, colloidal membrane at birth. Please remember the hint is this. There are only few conditions which present with colloidal membrane. I don't know why you all are getting confused. Please remember colloidal membrane, three ichthyosiform disorders. One is lamellar ichthyosis. The next is a variant of lamellar ichthyosis which is known as, there is a variant of lamellar ichthyosis which is known as bathing suit ichthyosis, and third is non-bullous ichthyosiform erythroderma. Non-bullous ichthyosiform erythroderma. Only these three conditions present with colloidal membrane at birth. The rest all like ichthyosis vulgaris, X-linked ichthyosis, epidermolysis hyperkeratosis, they do not present with the colloidal membrane at birth, and that is the clue in this question. So you have to mark option number 3 if they are marking or if they are giving colloidal membrane term in the question. Clear? Next, which of the following are the epidermal melanin disease? Which of the following are the epidermal melanin disease? Which of the following is epidermal melanin disease? Now please remember the hyperpigmentary disorders we have classified mainly into two groups. Epidermal melanin disease, where the excess pigment or excess melanocyte proliferation is present in epidermis. Another is dermal melanin disease, where the excessive pigmentation is present inside the dermis. Now please remember there are two ways where you can find whether the disease is inside the epidermis or inside the dermis. If it is brown in color, let me change the color of my pen. If it is brown, it means that the disease is present in the epidermis. But if it is blue, it means the disease is present in the dermis. Why there is change in color? Because when the light enters the dermis, because of the difference in the refractory error, obviously there is a difference in the refractory error, so the color of the reflected light changes. So if you have to look, if the lesion appears blue, you can easily or you can make sure that it is a dermal melanin disease. We have three examples under the dermal melanin disease. One is nevus of Ito, another is nevus of Ota, and third is Mongolian spot. But in epidermal melanin unit, the examples are Baker's nevus, freckles or lentigens. So the correct answer for this question becomes option number 1. Both of Baker's nevus and freckle, both of them are epidermal melanin disease. But dermal melanin disease are the other two, nevus of Ito, Ota and Mongolian spot. So you can see this is a very classical example or image of nevus of Ota. You can see bluish discoloration on the face. Nevus of Ito, bluish discoloration on the back. Okay. Now the next question is a assertion reason type. What is the correct answer here? What is the correct answer here? So the question is, topical hydroquinone is effective in melasma, and the reason is hydroquinone is a tyrosinase inhibitor. Now what happens in the patients of melasma? The main problem is more and more tyrosin is getting converted into pigment, and this step is catalyzed by an enzyme which is known as tyrosinase. This is catalyzed by an enzyme which is known as tyrosinase. Now if you inhibit this enzyme, the conversion is reduced and the excessive production of pigment can be avoided or prevented. And that is why we are using some of the treatment modalities like hydroquinone, which is a tyrosinase inhibitor, and it is proven to be effective in the patients of melasma. So please remember, both these statements are correct and they are the exact explanation of each other. Okay. Mongolian spot is a normal finding seen in the newborn. Yes, Aman, in a lot of individuals you see a Mongolian spot. What exactly is Mongolian spot? There is excessive pigmentation or there is arrest of the melanocyte in the dermis because of some problem during the embryogenesis. So you can see it in a lot of individuals, and it is usually seen that as a child grow, it tend to resolve or lighten up in the color. Okay. Next. What is the correct answer here? We have diagnosed a patient with vitiligo based on the history, physical examination and wet lab finding. Which of the following test is also warranted? Which of the following test is also warranted? Anybody can tell me the answer? Anyone? Very nice. Now we have diagnosed a patient with vitiligo. What is vitiligo? It is an autoimmune disease where T lymphocytes have damaged the melanocyte. Now please remember, autoimmune diseases have a nature that they usually present in groups. So that is their nature. They are never present alone. So if you have one autoimmune disease, always try to look for other autoimmune conditions associated. For example, the most frequent association is with that of thyroid disorders. Thyroid disorders are very frequently present in the patients of vitiligo. So the correct answer of this question is option number 1. Clear everyone? Next. "15 cm macule on an adolescent male undergo changes such as coarseness, growth of hair, acne. What can be the diagnosis?" Very well done, all of you, amazing. Please remember, this is a very classical image of a baker's nevus. You can see that there is a greenish lesion which is present on the yes. So Sharma, in the last question, if you have to do one test, you always try to do a test of thyroid, because in a majority of the vitiligo patient we find an associated thyroid disease. So whenever we are diagnosing a vitiligo patient, we try to find out the other associated condition so that we can treat them with time or early in the time so that it do not worsen the condition. So we try to do a thyroid profile in majority of the cases. Now here why it is Baker's nevus. First of all, the hint is adolescent male, brownish patch with increased hair. Very classical of thyroid, very classical of Baker's nevus. Now why adolescent? Because Baker's nevus, these cells have androgen receptors in them. So during the puberty, the androgen circulation increases and these nevi, they also increases in size. Okay. So with this, we are done with the today's session. I hope everybody have understood that. And before we go ahead, I would request all of you, if you want to subscribe any of them, please use my code, and my code is Chesta10. So thank you all of you. Good night and take care.